That's yours.
Good afternoon, everyone. Guys, can you hear me well?
Hey,
Yes.
we can hear you.
Okay,
Yeah.
thank you. All right, so I think maybe Sadie asked me about pre-op clearance or case about pre-op clearance. So in a nutshell, there are always guidelines about pre-op clearance for patients. And what you need to understand is pre-op clearance, what you would do in pre-op clearance is similar to what you would do in other cases without pre-op. In other words, if you have patient with suspected acute coronary syndrome, unstable angina, and STEMI, whatever you call it, it's reasonable to do heart catheterization. If you think that your patient is going to have severe CAD disease because symptoms are very disabling to the point that hey, doc, I can't walk for a few feet without having angina symptoms. In that case, also some kind of ischemia eval is reasonable. If your patient is going through high-risk surgery, such as vascular surgery or brain, intracranial, or thoracic surgery, in that case, stress testing is reasonable. Otherwise, actually, medical optimization is reasonable before surgery without further testing. Just always remember that, if your patient in acute congestive heart failure, you have to diurese them, make sure that they are on guideline-directed medical therapy, and just make sure they are optimized before surgical intervention. But I don't want everybody to think that any time or any kind of surgical intervention needs nuclear stress test or needs some kind of cardiac investigations. Now, most of the time, if you are on any patient, any case, you have to know your EF, and if your EF is acceptable, in that case, your outcome is going to be good. If your patient is able to do 1 block, 1.5 a block, walking without issues, without major issues, without disabling symptoms, your patient is going to do well during surgery. And, remember, elderly patients, they're going to have severe pulmonary hypertension, a lot of them, and severe TR, a lot of them. I don't think any one of my patients above the age of 85 without moderate to severe TR and pulmonary hypertension of 50 to 60 millimeters of mercury, a lot of them, they have that. It's part of, HFpEF and stiffness of the heart and chronic smoking and chronic lung disease and so forth. So if they're going to have surgery, they're going to have surgery. You just try to medically optimize them and go forward with it. They don't need to be on beta blockers. You don't have to initiate beta blockers prior to surgical intervention. This data was in the 90s, and that was not very accurate. Now, if your patient on beta blocker already, just keep doing that. If your patient not taking beta blockers, don't start it. If your patient with history of atrial fibrillation or DVT-PE on anticoagulation, you can stop the blood thinners anticoagulation safely for 2 to 3 days. No big deal, no need for bridging. Even nowadays, guys, to be honest with you, if you have aortic or even mitral valve, mechanical mitral valve, I don't do the bridging hardly unless the surgeon requested that Coumadin should be out completely for over 5 days. So for aortic valve, if the mechanical aortic valve, and at the same time you have high-risk patient history of stroke or atrial fibrillation, bridging is reasonable. If you have mechanical mitral valve, bridging is reasonable. Bridging should be, Lovinox, GFR, calculated dose, 1 milligram per minute, twice a day, or once a day, depends on the GFR, if the GFR above 30 or below 30. That's pretty much it. Just medically optimizing your patient, and don't let the surgery scares you. If your patient is stable, they should be able to go through surgery. And if the surgery is going to be major surgery, and your patient is suspected based on the physical exam, based on the risk and so forth, that they're going to have severe disabling CAD disease like left main or triple vessel disease, that the pre-op clearance is gonna help you identify something like that with stress testing, in that case, go ahead and do the stress test. Otherwise, just let it be and just move forward with the surgical intervention. For endocarditis prophylaxis, if you have few things you have to remember, any kind of prosthesis, prosthetic valve, mechanical or tissue valve, they have to be on endocarditis prophylaxis. Or if they have history of endocarditis in the past, they have to be under endocarditis prophylaxis. Or if you have uncorrected congenital heart disease, which you don't see anymore, I don't see that, uncorrected congenital heart disease. In that case, endocarditis prophylaxis indicated, otherwise is not indicated. You get that? So history of endocarditis in the past or any kind of prosthetic valve you need. Now, if you have Watchman or amulet for 6 months only, if you have the implanter device, the ASD occluder device, only 6 months. Beyond that, you don't need to do antibiotic prophylaxis for endocarditis. Is that clear? Any questions about that? One more thing, aspirin. If you have history of MI or stent, I would recommend to continue the aspirin, regardless of the surgeon thinks. So you have to just make it in your note. You have to do your surgery on antiplatelet agent. Now, if the surgery is going to involve intracranial stuff, in that case, you may be able to stop with high risk, but you don't really want to have your patient going through the stress of surgery if they have few stents without some kind of antiplatelet agent. The risk of having bad outcome is bad. And nowadays, everybody does surgeries on antiplatelet agent, namely aspirin, 81 milligram.
What's your antibiotic of choice dosing for prophylaxis?
Yes, usually clindamycin if you have GI surgical intervention, and if you have facial, skin, or dental, the antibiotic of choice is amoxicillin 2 grams, and if you have penicillin allergy, azithromycin 1 gram. You take it half an hour to 1 hour prior to the surgical intervention. Any questions, guys?
How long are you holding anticoagulation for before most procedures?
48 hours guidelines, and now some high risk surgeries, they require such as CV surgeries, intracranial surgeries, 3 days. And if you think that your patient has chronic kidney disease, 3 days, but should not be more than 48 to 72 hours. And actually, I presented data to the Structural Heart Committee at Memorial Hospital multiple times because surgeons would like to stop it for 7 to 10 days based on the guidelines. I went through their guidelines. It's weak evidence, and our ACC, HRS guidelines say differently, 48 to 72 hours, because the clearance of these medications is really very high. Unlikely that you're going to have anticoagulation effect beyond 48 hours.
And then how quickly to restart after?
ASAP, as soon as the surgeon. So usually it depends on your surgical outcome. If you're a surgeon and you think that the area bled a lot and there's high risk of bleeding, then you can do that in your recommendation. So prior to surgery is us, after surgery is the surgeon. But as soon as possible. That's how we do that.
So in nursing homes, we see a lot of dental procedures, which are known to bleed. So reasonable to maybe hold 24 hours after and then resume, or
Right. I'm okay with that. I mean, usually I've never seen patient having issues if you hold anticoagulation for a long time, except one patient. Actually, I saw as a second opinion. I ended up implanting Watchman. Every time they stopped anticoagulation for atrial fibrillation for 72 hours or something like that, patient ended up having, for colonoscopy, patient ended up having massive stroke. So what I did Watchman on that patient, and since then, no issues. Doesn't need to be on anticoagulation except antiplatelet. So we're good. Any other questions, guys?
I have a question, Dr. Ibrahim.
Yeah, Nelly.
I usually, when I do my pre-op evals, I usually document low risk, low moderate risk once I've evaluated the patient and the procedure. Any thoughts about some of the fancier risk stratification cardiac scores? The Goldman index is something that I've seen, and I think the Gupta perioperative risk scores.
Yeah, it's really complicated. It's never practical, in my opinion. Nobody understands what the scores means and why you use it. What I would say, there are two parts of the risk stratification. One part is the surgical intervention, and the other part is your patient. So what kind of patient you have, if the patient has high risk, and what kind of surgical intervention they're going to have. If anybody above the age of 80, you're going to have intermediate risk for any surgery. So I would be just identifying that based on how you feel about it. I think the risk scoring and all of that, which came in documents recently, actually, I wouldn't really, I'm not worried about that, and I think it's going to complicate the issue. The general surgeon doesn't care about that. A neurosurgeon don't care about that either. So I think what we just do you think your patient needs to have any kind of procedure, a heart procedure, to mitigate any risk during surgical intervention? Yes or no? Number two, is there anything we can do medication-wise or optimization-wise to prepare your patient to surgery? Number two, that's important. Number three is, what should we do after surgical intervention? That's how is going to be your main take of any kind of pre-op clearance for your patients. But I mean, complicating it with risk score, I was never fan of Framingham risk score, even though I did freaking studies during my training about Framingham risk score. So it just needs something practical that you're going to remember, that's going to be helpful, and that's may help you identify your risks. Sometimes, the eyeball thing is very important, the surgical eyeball, the way you look at your patient. Your patient is 75-year-old chronic smoker, bedridden, screwed up. His outcome is going to be much worse than somebody who's 86, able to go and have a meal and come back without cane, without wheelchair, without walker. So I mean, it's a lot of subjectivity, but the guidelines really don't want you to be aggressive in patients and ordering tests back and forth, right and left. That's not going to change much of your outcome. If you have a 90% mid-LAD stenosis, who cares, honestly? I mean, it is 19% mid-LAD stenosis, but if you stent that lesion and put foreign body in that lesion, that you have to be on antiplatelet agent for at least 6 months, did you really help your surgical outcome? I don't think so. Based on Courage trial and ischemia 1, ischemia 2 trials, no. Anything else?
Maybe do a quick little blurb about, do we need to hold like a Jardiance or Farxiga, or?
Yes, actually, Jardiance and Farxiga right now, they need to be held for 3 days, 72 hours. I learned the hard, I don't claim that I really read the anesthesia literature, but I learned the hard way. There's a new anesthesiologist at Memorial Hospital, told me, Doc, you want your procedure. Procedure was elective for somebody for AFib ablation. I told him why. He told me, do you want to claim it as emergency or urgency? I told him why. He said, your patient took Jardiance today, and that's associated with acidosis, metabolic acidosis. So I told him, oh shit, okay, yeah, do it emergent. So we had to claim it as emergent, but now you have to stop for 72 hours actually, for Jardiance and for SGL2 inhibitors and SGL1 inhibitors, which is Impefa, Jardiance, and Farxiga.
Totally not a little bit connected. Let's say we get a patient into the nursing home with a pacemaker. This is one I also often see. How quickly can the bandage come off, and what about the steri strips?
Perfect. So the bandage can come off 3 days after procedure. You want to expose it to air. Air is antibacterial. Air is antibacterial. Moisture and lack of air, good for bacteria. So always remember that. Stir strips will stay there because stir strips has micro holes in them. It will prevent water, moisture, and at the same time, it will maintain air entrance to the incision. So I would leave the stir strips. Stir strips will fall out after whatever showers and stuff like that. So just remember that the bandage can be removed 3 days and just leave the stir strips. Make sure that your patient, I don't do staples, but if any of your physicians has to have staples, that should be removed within 7 to 10 days.
And I guess while we're talking about it, let's talk about sternal precautions post-cabbage, how long and what those precautions are.
So every sternal precautions, it's similar to any incision actually. It depends on the surgeon. Some of these surgeons actually they put glue, dermabond. Some of them they just do stir strips. Some of them just cover the whole area. They don't want anyone to remove it within 7 to 10 days. My experience and with our surgeons, they really want to look at the incision. Don't you think so, Gabe? They want to look at the incision as a CV surgeon. But they just want their patient to come back and check the incision themselves, or they don't care.
I've seen open, like at Union and.
Okay,
By the time they leave the hospital, it's open
Mhm.
with glue.
Yeah.
okay, so it's open with glue and just
And
leave it alone.
The concept of being in a tube
Mhm.
is
Yeah,
for
the-
any sternal precautions.
Right.
Don't use that arm to
Okay.
push out.
Okay, well, that's okay.
6 weeks, yeah, no pushing or above the head for sternotomy.
Okay, so no pushing or up the head, and
I
just be
think it's
careful with
5
tracking.
1 week, they're not allowed to push off the bed.
Okay. All right, well, that's actually important because they don't really want to have a crack in the chest.
Because we have one at Pam right now, and his chest is open. Bad.
Yeah,
Like open,
by
you
incision,
can see everything.
right? That's by secondary intention.
Trying to also think of along the surgical lines.
Any other questions, guys, you have? All right, so
Arm in the sling post pacemaker.
yes, only at night time, and I wouldn't keep it beyond 24 hours, and I don't really want to keep it for a long time at all because you're gonna have frozen elbow, frozen shoulder. So I wouldn't keep it. I'm against it.
Range of motion, just not above the head.
Exactly
And
right.
five
10
to
pounds. 10 pounds in the left arm or right arm, depends. Uh, okay, so I sent everybody the new article in New England Journal of Medicine. Actually, it's a testament to what we've been doing, advocating for. So a lot of anticoagulation, antiplatelet, antithrombotic agents is not really the way we have to do medicine nowadays. Even if your patient has acute myocardial infarction, stent, or whatever, beyond 6 months, you should not continue the antiplatelet agents. So I would take it with a grain of salt if your patient on anticoagulation. Now, remember, those patients are on anticoagulation, right? So, I mean, if you feel that your patient is a little bit anemic beyond 10, I would not continue with antiplatelet, just keep anticoagulation and let it be. Is that fair? Okay. So keep that in your mind. Less is more. Less is more. Anticoagulation trumps everything. You want to cover the PE, DVT, the AFib aspect. But at the same time, you don't want to throw a lot aspirin or Plavix for a long period of time that you're really not changing the outcome of your patient, but you're actually the cardiovascular mortality in that article was higher in the aspirin arm. That's pretty bad. So just keep that in your mind. Less is more.
Question about that.
Mhm.
You have a patient that's on dual antiplatelet, Brilinta and aspirin, or Plavix and aspirin. If you have to get rid of one, let's say the patient's becoming anemic, which would you rather them keep? Aspirin or like the Brilinta, Plavix, etc.?
Brilinta or Plavix. The antiplatelet agents seems to be for the first year after intervention. I would keep the aspirin, Plavix, or Efient for at least 1 year, and then beyond 1 year, I would do only aspirin. There's really no data beyond even 1 month. Can you believe that? After the intervention, but nowadays these geniuses in intervention in the community, they like them for at least 1 year. so we can keep them for 1 year and then switch to aspirin. I don't think you need to keep any of your patient Plavix on Efient or on Brilinta 1 year after 1 year beyond the intervention, unless they have a reason for them not to be on aspirin. GI discomfort, aspirin-induced allergies, asthma, whatever. Aspirin-induced asthma, obviously, but otherwise, I would switch, especially these elderly patients with high risk of bleeding. As Plavix, Brilinta, and Efient, they tend to bleed a lot, actually. All right, any questions about that? Always remember the anticoagulation. After beyond 3 to 6 months, you can cut down on the anticoagulation from 20 in the case of Xarelto to 10 for prophylaxis, and in the Eliquis from 5 to 2.5. Okay, and then beyond 1 to 2 years, then even in unprovoked DVT-PE, it's a shared decision. If you think that patient is anemic, hemoglobin 8.5, 8.6, 8.7, I would just stop the aspirin, I would stop the anticoagulation completely and see how you do. Is that fair? Elderly patients, if you have a patient, check medications. Today I had patient came into my office. The fingers are blue, literally blue, where they were not able to get O2-sat on that patient, and turned out that this 79-year-old who's 150 pounds, his on metoprolol tartrate 100 twice a day. That's gonna cause freaking vasoconstriction. I had a patient who was referred when I was in training for peripheral vascular intervention because of claudication. He was on 100 twice a day. We cut down on the metoprolol and patient was back to normal. So just be careful about over-medicating your patients. That should not be acceptable. Obviously, it was primary care / whoever doing that to this patient, but that's not the way you do it. If you feel that patient needs to have combination of medications, just combine a little bit of deltazim, cardizem, and beta blockers. And if your EF is low, then you send your patient for, let's say, evenal ablation, AFib ablation, whatever. But I mean, these high dose of medication should not be acceptable. So what I did, I stopped the metoprolol tartrate, started Toprol XL. You can't just stop high dose beta blockers without weaning them off. So probably we'll cut down to 50 once a day of Toprol XL for the time being in the next few weeks, and see how patient reacts. He was a smoker until he got his lung cancer about 4 years ago. So he has COPD. The COPD is getting exacerbated by high dose beta blockers. Even if you have beta 1 selective beta blockers, you still have spillover of beta 2 activity, and you're going to get these vasoconstriction, these bronchoconstriction, bronchospasm from the high dose beta blockers. So be mindful, be careful. I don't think your 86-year-old patient should be on 40 of rosuvastatin or 80 of atorvastatin. I would cut down on these medications and be careful about the polypharmacy. There's actually a story I always mention. My mentor, James Willerson, when I was in Houston, one time I was presenting patients to him, one patient, obviously you have to remember everything top of it. So 11 medication on one of my patients, 80 plus years old. He told me, stop all of these medications except one. I told him, which one? He told me, I don't care. So, I mean, just polypharmacy. We have to be very careful about over-medicating our patients. Questions about that? Okay, so I think I got these points that I was planning to talk about. Always remember the GDMT. Be mindful about your patients. We had a few cases, 2 or 3 cases over the last few weeks. Patients ended up having acute kidney injury, a little bit elevation in creatinine because of metolazone. So I always learned when you do metolazone, just be careful about short period of time. And if you want to space it, just do it a couple times. Like today, I had one of my patients on Saturday and Friday, or Saturday and Thursday, she takes metolazone. So space it out. Don't just give it 5 milligram once a day for a month. the elderly patient will have acute kidney injury. Now, certain patients may need it, and some of your patients may end up having cardiorenal syndrome. It is what it is, but be very mindful about very strong medications, high dose of Bumix, metolazone, high dose aldactone. So, careful about these medications. Always, if you feel that you need to check blood work, do it. I'll tell you this, I'm not sure if Ageline with us. I mean, she does check blood work quite often for certain patients. I don't blame her. I think that's reasonable. If you feel that you can do some blood work, prevent your patient from going into hyperkalemia or acute kidney injury, do it. It's much better to do stuff like that, which is gonna make probably cost about 80 to 120 bucks versus hospital admission, which is gonna cost 15, 20 grand. Okay, guys. Anything else? Any other questions, concerns? All right. Nice to talk to you. Thanks for your hard work.
All right, thank you, everyone. We'll chat later.
Thank you.